Right, so my name is Samuel Soto, student physical therapist. Today we're going to be talking about abdominal aortic aneurysms, interventional planning, and follow-up. So, general overview to the presentation. We're going to start off with an overview of abdominal aortic aneurysms, which at times I'll call AAA. And we're going to talk about differential diagnoses, diagnostic imaging, interventional planning, and then follow-up. Lastly, we're going to conclude with a patient case with physical therapy interventions for a patient I worked on during my first clinical affiliation. So, a general overview of abdominal aortic aneurysms. There are different types. So, you have like saccular, fusiform. You even have false aneurysms called pseudoaneurysms. Essentially, there are just basically different sizes of aneurysms. But what they all share in common is that it's an abnormal dilation within the arterial wall that arises below the thorax. And most of the time, these aneurysms are below the branches of the renal arteries. So we most of the time call them infrarenal aneurysms. So they are a significant cause of mortality for adults over the age of 60 years old. They are more common in men, and some of the causes are very similar to cardiac disease and peripheral vascular disease. So you're going to see smoking, hypertension, obesity, atherosclerosis, but there's also a genetic component here. So taking a family medical history is pertinent to the evaluation. These aneurysms are identified on diagnostic ultrasound screening as an infrarenal aortic diameter equal to or greater than 50% of the normal diameter for that particular sex and age. There's an incidence rate of 0.4 to 0.67 in the Western population, a prevalence rate of 4 to 8%. And in terms of the prognosis, when you have a large AAA, 80% tend to be fatal. So it's very important that we screen before they actually rupture. So just a review of the anatomy here. The picture on the left, we have the great big vessels. We see the aortic arch. We see the descending aorta, thoracic aorta. And below the level of the kidneys is really where we're going to focus on. So again, that's the infrarenal abdominal aortic aneurysm. And as you can see the picture on the right, there's also other important vessels like your middle adrenal and your renal arteries, as well as your inferior mesenteric, which supply your GI system. So as a differential diagnosis, there are a lot of structures within this abdominal region. So we want to remember all the quadrants, like your upper quadrant, your lower quadrant, etc. You have your stomach, you have your pancreas, your gallbladder, you have your bowels, like your large intestine. So any kind of bowel obstruction, any kind of stomach, perforation or ulcer can kind of mimic pain within that region. Also, acute cholecystitis, which is basically inflammation of the gallbladder, can cause similar symptoms. And even kidney stones can cause similar symptoms. So it's very important that we know that there's also alternatives in terms of diagnosing. So when it comes to like differentiating abdominal aortic aneurysms and GI system disorders such as infections, inflammation, or even tumors, it's important to note the main differences. So when it comes to the AAA, you are most of the time going to have a palpable pulsating abdominal mass. And if everyone just kind of like go below your xiphoid process, go a little bit below that, and just kind of press inwards to the posterior side, you should feel within your finger pad. You should feel a pulsating, a pulse basically. However, if somebody has this AAA, you're gonna feel a very strong pulse, and it's not really gonna go away as you go lateral towards the abdomen. You're pretty much gonna feel it very lateral to where that aorta is supposed to be. Patients may also have midline, lower thoracic, and lumbar pain. And what's kind of scary is a lot of the times patients are asymptomatic at the time of diagnoses. However, when it comes to the GI system disorders, you're going to have that rebound tenderness in which when you poke into the abdominal structures and you come out, that's when the patient's going to have the pain, not so much when you're poking in. You're also going to have nausea, vomiting, and constipation or diarrhea, which is more indicative of that GI system disorder. So moving on, when it comes to diagnostic imaging, we're going to first talk about ultrasound. So ultrasound is the standard method of screening and monitoring for these abdominal aortic aneurysms that have not ruptured. And what's great about ultrasound is that it has a sensitivity of nearly 100% in the diagnoses. Some of the advantages of ultrasound are going to be lower cost, it's widely available, and it's also non-invasive. So you really just need gel, the ultrasound head, and then the projection. However, the downfall of ultrasound is that it might be suboptimal in patients with excessive adipose tissue. It's going to kind of distort the view a little bit. Also, patients who have increased bowel gas might be a little bit difficult to visualize. So the picture here on the right is of the ultrasound, and it is a longitudinal view of the aorta. So as you can see within the black arrows, we see that aneurysm there, that big bulge is pretty obvious to see there. So this is kind of like a blown up picture of the ultrasound method of screening for the AAA. Just remember to use a lot of gel, and you might have to wiggle around the ultrasound head because remember your anatomy, you have your inferior vena cava parallel to your abdominal aorta. So sometimes you have to really differentiate between what vessel you're looking at. So it does take a little bit of practice and training. Moving on to the CT scan of the abdominal aorta. This is great because it's non-invasive. It's highly predictive of aneurysm size, and it has largely replaced older, more invasive methods. However, some of the disadvantages of this CT scan is that you need contrast, and it uses an ionizing radiation, so it does expose the patient to radiation. So here on the picture on the right, we do see a CT scan of the abdominal aorta, and it is at the level of the kidneys. You can see very clearly the kidneys on both sides, and you can see that clear picture of that vertebra. Remember, CT scans are very good for bone, for visualizing bone. So you do see that beautiful outline of the vertebra. And here in the middle, you do see that aneurysm within the white lines. And I also want to point out that there's also a small amount of mural thrombus along the posterior and lateral walls of the aneurysm. Essentially, what a mural thrombus is, it's a thrombi or a blood clot within the wall of the vessel. So not only are CT scans great for visualizing the aneurysm and knowing what kind of size it is, but it's also good for showing nearby structures and nearby impairments such as that mural thrombus. So moving on to the CTA, I actually didn't know what a CTA was until doing more research before presenting here, but it's actually very interesting because CTAs combine the CT scan with a dye, and then it uses 3D rendering to create a three-dimensional picture in which you can really truly evaluate the vessel lumen, the nearby vessels, as well as the cross-sectional area and sac volume through reconstructed images. The only thing is that there may be a potential for nephrotoxicity, and this is because you're using a specific iodinated contrast material. So it's very important that we screen patients for any kidney disease before applying specific diagnostic imaging tools. So here the picture on the right, again, it's a CTA, a computed tomographic angiography, and it's showing a bilobed infrarenal aortic aneurysm. Now remember, infrarenal, it's below the kidneys, and you see those two big lobes within the white arrows. What's good about the CTA is, again, it shows nearby vessels. So within this black arrow here, it's actually showing the renal artery, and there's actually stenosis going on there. So the narrowing of that artery. So CTAs are, again, they're great for knowing how big that lumen is, nearby vessels, and also the sac volume. So the MRA, or the magnetic resonance angiography, it's going to be a bit better soft tissue categorization than the CTA, than the last one we saw, the computed tomographic angiography. So better soft tissue categorization. It also may assist clinicians with differentiating slow-growing aneurysms from fast-growing aneurysms. So you see the picture here on the right. There's definitely a better soft tissue categorization. You see all those structures a little bit more clear than the CTA. And the problem here is that it takes a while for the scan to complete, so it has a long scanning duration. There's also decreased spatial resolution, and I think the worst problem here is going to be that GBCM, which is basically like a gadolinium-based contrast material that has been linked to kidney problems. So again, kidney screening is very important before knowing which diagnostic imaging tool to use. So the picture here on the right is an MRA. It is of a 79-year-old man with an infrarenal aortic abdominal aneurysm. And you see that big sac right there. So the goal of managing a AAA is going to be to restore the aortic lumen integrity and to prevent ischemia to vital organs. Now, I want you guys to really remember the preventing ischemia to vital organs, because that's going to come into play when I'm talking about the patient I was treating. So essentially, we know that the patient has an abdominal aortic aneurysm. Now it's like, what are we going to do about it? What technique, what surgical approach is the surgeon going to go with? Now, a lot of the times it depends on the size of the aneurysm, on the aortic neck morphology, but I really want to focus on two techniques here. The first one is going to be the EVAR technique, the endovascular aneurysm repair technique. The second one is going to be the open repair, which is a more invasive. Now, the two here in the middle, I'm not going to talk too much about, but they are basically the fenestrated and the percutaneous EVAR. There are more specific approaches. So we're going to compare the EVAR and the open repair. So the picture here on the left is showing that endovascular repair, in which they use a catheter to insert the stent graft, and then they put the stent graft into place. However, here on the right is our open repair. It's more invasive. They're going to make a really big stitch in your abdominal area. They're going to put that graft in, and they're going to stitch you back up. So the studies have shown that with the EVAR repair, there is decreased perioperative mortality and also decreased length of hospital stay. So whenever the surgeon has the opportunity to use the EVAR, they are most likely going to. However, sometimes aneurysms rupture and there's not enough time to perform certain techniques. So an open repair may be the only feasible option at the time. So when it comes to planning for the EVAR or open repair, we're going to talk a little bit about which procedure is appropriate. And the two most appropriate are going to be the CTA of the abdomen and the MRA. Now, if I just go back, I just want you guys to know, to be reminded of the CTA is this one, and the MRA is that one. So those are the two that are usually most appropriate. And if you look at the relative radiation level, the CTA is a lot higher than the MRA. Now, when it comes to a follow-up after the EVAR or open repair, it's going to be the same thing. The CTA and the MRA are going to be your go-to options. However, there are more appropriate options. You have your aortography, you have your CT of the abdomen, and you also even have your MRA of the abdomen and pelvis. So when it comes to follow-up, patients are going to be receiving diagnostic imaging at 1 month after the repair, 12 months, and then every year after that, just to make sure that everything is going well. And the CT and the CTA are going to be the best tools for evaluating how the aneurysm is progressing. So I just want to talk a little bit about a patient case. So during my first clinical affiliation at New York Presbyterian Queens, I had the privilege to work with a 63-year-old male who was status post open repair for abdominal aortic aneurysm 10 months prior to that date. This was back in February. He was rushed to Cornell Hospital for emergency surgery due to an aneurysm rupture. And shortly after that, he did his rehabilitation at Burke before starting outpatient PT with my CI and I. So what ended up happening was he had complications during the surgery, which resulted in ischemia to the spinal cord, and then that resulted in paraplegia of both legs. So the reason I bring this up is because I want to emphasize the relationship between the circulatory system and the nervous system. So they're very integrated. The way that your spinal cord receives blood is through that abdominal aorta. Well, a lot of the aorta, but particularly in this case, the artery of Adamkiewicz comes off of that vessel, and it supplies blood to the anterior spinal cord. As we know, the anterior spinal cord is involved with motor function, so if you have ischemia to this area, you're going to have decreased neurological functioning in terms of motor output. So this patient did have paraplegia. He did have weakness in his legs. And one of the things I'll always remember was that he would always say that he had numb pain. He was always numb. He always had pain. And his English wasn't the best. So what ended up happening was, it was very hard to communicate with him and understand what was going on. So like the first few weeks of treating him, we were treating him with a very general approach. And we would always tell him, can you please bring in your medical records? We need more information to kind of help you out. And he pretty much forgot every single time or didn't want to. And then one day he came in with a huge stack of papers, and that's when we found out that he had a T6 incomplete spinal cord injury because of this aneurysm rupture. So why is this relevant for a physical therapist? Well, this is relevant for a physical therapist because, as we learned, abdominal aortic aneurysms can refer pain to the low back. It can be a differential diagnosis for something else. So in this resident's case problem, a physician actually wrote a prescription to a physical therapist that said low back pain, evaluate and treat. And after further evaluation, luckily, the physical therapist has had great training. He actually realized that the patient had an abdominal aortic aneurysm, and obviously the treatment is completely different. So as physical therapists, it's very important that we understand the vascular system, the nervous system, not just the musculoskeletal system, because patients might be coming in with something completely, totally different, and it's time sensitive for their life. Thank you.